Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, MARKUS at Home welcomes Professor J. Radhakrishnan in New York City, New York, and Professor Jonathan Barratt in Leicester, England, United Kingdom, in order to discuss the treatment of IgA nephropathy, which is the topic of a recent review paper and the treatment standard paper, both published in NDT, authored by Dr. Radhakrishnan and Dr. Barratt, respectively, which NDT's editor-in-chief, Professor Joachim Anders, Professor Andreas Kronbichler, and I picked as our papers of the month for a detailed NDT MARKUS at Home webinar. Dear Jay, it's an honor and pleasure for us to host you for the first time at our channel. Dear Jonathan, welcome back after our Best of ERA 2025 Congress webinar.
Thank you very much.
It's a great pleasure to host you both, and Professor Radhakrishnan is the clinical chief of the nephrology division at Columbia University and the editor-in-chief of Kidney International Reports, a really outstanding journal for us as clinical nephrologists. And Professor Jonathan Barratt is working at the Department of Cardiovascular Sciences at the University of Leicester and leads the Mayer IgA Nephropathy Research Group in Leicester. Both are well known for their contributions in glomerular diseases and particularly IgA nephropathy. And we are looking forward to your presentations and to the Q&A afterwards.
So thank you very much for having me on this talk series. And we shall start the session by outlining a little bit on the epidemiology. And as you know, there's been a lot of advances from John Barratt's group about what is going on with the prognosis in patients with IgA nephropathy. And then we will dive into the new 2025 KDIGO guidelines, preceded by the relevant trials that essentially led to these guidelines. So these are my disclosures. So the epidemiology is fairly well characterized in 2025. And to outline the RADAR study key findings, this was a UK cohort, and there were a large number of adults and children. And if you look at IgA nephropathy, they were at a higher risk from the outside. So you can see the proteinuria levels were over 0.5 grams per day, and the GFR was under 60. And if you look at their follow-up, which is about 6 years, a significant number, 50% of patients, either reached kidney failure or died. And what is very, very important is the level of proteinuria at which the risk starts. And you can see it starts as low as less than 0.4 grams per day, and there's an incremental risk of kidney failure when you reach the highest quartile, which is 1.76. So this is very bad news of sorts, but what is important is what used to be a benign disorder, thought to be a benign disorder, is not so benign. So I shall frame the KDIGO guidelines through a patient's journey. This is a patient I recently saw. He's a 35-year-old South Asian male and was told to have proteinuria during a routine physical back in 2022. And if you look at his workup, nothing was really done for about a year. And a year later, he did have impaired GFR. For a 35-year-old man, the GFR of 62 is low, and his proteinuria was 2 grams. So he fits the high-risk group in the RADAR study. He was put on an ARB. He's also hypertensive, with which his blood pressure came down nicely. He had a completely negative serological workup, and besides a grandfather who had diabetic kidney disease, there was no other family history. A biopsy was done, and the initial assessment is that when you do a biopsy, you need to rule out secondary causes associated with IgA nephropathy, and these are listed here. And when you make a diagnosis of idiopathic IgA nephropathy, you should look at the risk score. The KDIGO has outlined a threshold proteinuria level of 0.5 grams per day or equivalent as the time that you should do the biopsy. And the MEST code is really what is next, and that has been well validated in multiple populations in terms of prognosis. And you can see this patient had a descriptive, on the biopsy, had focal crescentic and endocapillary proliferative GN, consistent with IgA nephropathy. He had 30% atrophy and fibrosis in the interstitial compartment, and 2 glomes had sclerosis. So this calculates to an M0, E1, S1, T1, and a C1. And the next step is to at least get an estimate of what the prognosis is of this patient over the next 5 or so years. And this was the International IgA Prediction Tool, and it takes several clinical and the MES score into a prediction model that will tell you over 5 years or at any time up to 5 years after the biopsy, what is the chance of a 50% decline in GFR or kidney failure. And this score has been also extended to pediatrics, and it's extended to 2 years from the time of biopsy for a total time of approximately 5 years of prediction time. So in this patient, you can see his risk of progression, putting all these factors, is actually very high. It's 25% risk of a 50% decline or kidney failure over 5 years. So to paraphrase this patient would have been thought as being, okay, he's got about a couple of grams and, we can bring the proteinuria down very easily with, ACE inhibitors and so on. But the point is that his prognosis is not very good at this point in time. So I'm going to dive right into the KDIGO 2025 guidelines, which was just published last month. And the point is that this patient is going to lose 5 to 6 mLs of GFR per year. And the KDIGO's recommendation is to reduce it to less than 1 ml of GFR per year. And the best and the only validated early biomarker outside of the eGFR slope, if you will, is the urine protein excretion. And the target here is to get it below 0.5 grams and preferably below 0.3 grams. And it should be realized that if you've got patients who are well into the career of IgA nephropathy, there'll be extensive sclerosis. And that may not allow us to reduce the proteinuria, which can be from either sclerosis or active inflammatory activity in coming down. And it's also important to note that a single drug may not be enough. Multiple drugs and multi-targets should be considered when you treat patients with IgAN. So John Barratt will talk in detail about pathogenesis, but what we are trying to do with IgA nephropathy in the KDIGO guidelines is to look at the 4-hit model, hit 1 being the production of the GAL-deficient IgA1, antibodies to GAL-deficient IgA1 is hit 2, immune complexes is hit 3, and then the deposition in the mesangium is hit 4. And there's a pre-hit 1 where there's a production of these, there's a whole process that leads to the production of these antibodies, which involves B cells, and a post-hit 4 that leads to inflammation and fibrosis. So all these events need to be taken into account when we treat patients with IgAN. And the focus really, the whole paradigm here is now changed, is that we need to simultaneously look at hit 1, 2, and 3, and 4, and look at where in this targeted map can we use drugs most efficiently and optimally to control disease and prevent scarring and fibrosis. So I'll very briefly mention the key trials that were used to create the KDIGO 2025 update in IgAN. And this was the STOP IgAN study that was actually referred to in the 2021 guidelines, where patients were treated with supportive care or supportive care plus immunosuppression in essentially a European cohort. And he found that despite a reduction in proteinuria in the patients who had received immunosuppression, there was no difference in the maintenance of GFR or improvement in GFR. So this was considered a negative study, and there were side effects. And there was some concern that corticosteroids may not be the way to go in every patient with IgA nephropathy as outlined in the 2021 guidelines. And then came the testing study. The testing study was a multinational cohort with a lot of patients from East Asia, so very different from an ethnic standpoint. And they were randomized into a methylprednisolone group and a placebo group. And here we see that there was clearly a difference in terms of methylprednisolone doing better. But one should remember that testing study was stopped halfway because of severe adverse events and even deaths. And the protocol was changed. So one still needs to consider corticosteroids when being used with some degree of caution. And every patient may not be suitable, and there may be side effects one should be monitoring these patients for. But clearly this drug works, at least in this population. And the next study that was published was in the conservative or supportive arm. and that was SGLT2 inhibitors. This was a pre-specified analysis of the DAPA CKD population. And you can see the composite primary endpoint in patients with IgA nephropathy showed a much better outcome in the patients treated with the SGLT2 inhibitor compared to placebo, as also the composite of the kidney endpoint, which is 50% GFR decline, end-stage kidney disease, or kidney death, were much lower in the patients with IgA nephropathy. So this also forms what's called a key part of the treatment paradigm of IgA nephropathy in 2025. Then there were specific drugs that targeted the endothelin pathway. Now, as we know, angiotensin II has a whole lot of effects on causing damage in the setting of inflammation at the level of tubular interstitium, the glomeruli, as well as the endothelial cells. So, and it turns out that endothelin 1 through its receptor ETA does almost exactly the same thing. So the question is, can the combination work better than a angiotensin or a RAS inhibitor? And this was tested in the PROTECT study, which compared sparsentan with irbesartan in a randomized double-blind fashion. And there were two endpoints. The early endpoint was the reduction in proteinuria, and the key secondary endpoint was the GFR slope. And each of these had to be met for the drug to be fully approved. So if you look at proteinuria, there was clearly a difference in the two groups. There was a 48% reduction in proteinuria compared to 14% in placebo. And if you look at the GFR slopes, there are two slopes. There's a total slope and there's a chronic slope. Total slope starts from time 0 till the end of the adjudication period. And the chronic slope starts from the point where the dip in GFR has been stabilized, because of both these drugs do cause an initial drip. It turns out that the total slope was almost did not hit the p-value, but the chronic slope did. And as a consequence, this drug is now approved in some countries for IgA nephropathy. Then the last drug in this series that is mentioned in the KDIGO 2025 centers around the early events in the intestinal mucosa, where because of B-cell activation, there is production of the Gal-deficient IgA1, and this leads to the early events leading to the pathogenesis of IgA nephropathy. So if you look at a drug that is selectively targeting the Peyer's patches in the intestinal mucosa, and this is TR budesonide or Nefecon, you can see there will be a downregulation of events in the early parts of this IgAN pathway. So this drug was tested in the NefIgArd study. You can see in the first endpoint was a reduction in proteinuria. The Nefecon 16 milligrams led to a clear difference in the reduction of proteinuria. But you see, after the drug was stopped in this gray area, there is a slight worsening, if you will, of this proteinuria events. And very importantly, there was stabilization of the GFR while the patients were on the drug compared to placebo. But again, after stopping the drug, there was a decline in this GFR, suggesting that the effects do wear off once the drug is stopped. So here's the 2025 paradigm, if you will, of IgA nephropathy and how best to treat. So you look at the folks who are at risk for progressive kidney loss here, right here. And then you have to look at the two sides of the management paradigm. On the left is managing the IgAN-specific drivers for nephron loss. On the right is managing the genetic response to the IgAN-specific nephron loss. So on the left side, you have events like the 4-hit pathway, the inflammatory events, and so on. And on the right side are the sequelae of inflammation, which is fibrosis and loss of nephrons. So how can we stop the synthesis of the pathogenic forms of IgA and IgA immune complex? And how can we stop the immune complex mediated kidney injury, which is inflammation? And the two drugs that are now sort of in this paradigm is TRF budesonide and systemic glucocorticoids. And on the right side, other than, one should not forget that alongside CKD, there is a need to reduce cardiovascular risk. So please do use the calculators that are now available everywhere in terms of deciding about CV risk. We need to reduce glomerular hyperfiltration, reduce proteinuria, and the impact on the tubular interstitium. Blood pressure control is very, very important, less than 120/70. And towards this, there's a need for lifestyle modification, the specific use of RAS inhibitors or DRA, the dual endothelin and angiotensin receptor antagonists, with or without SGLT2 inhibitors. So patients may be on 3 different targeted pathways with or without the specific inhibitors of the so-called left side of this IgA treatment paradigm. So I'm going to end with the clinical course of this patient. His creatinine, remember, was 1.5. It was hovered around the same area, despite increasing the losartan and starting on dapagliflozin. So you can see his proteinuria went up even further. And he was started at that time on the TR budesonide, and he was switched from the ARB to sparsentan. His proteinuria dropped to 1.2. His creatinine improved a little bit to 1.25. Proteinuria dropped to 0.4. And at this time, he still has renal impairment, but it's much more stable. And the proteinuria is at a good level of 0.27 to 0.3. So the idea is that with this combination therapy, we've gained some control of his disease. What the future tells, we do not know. So just to conclude this section of the talk, IgA nephropathy arises from a multi-hit cascade. You may have GWAS, which John Barratt will mention, that can look at druggable targets. Although steroids are effective, there are side effects which are very, very significant. And we do have, in addition to targeted release corticosteroids, certain complement inhibitors have been provisionally approved, which is not there in this KDIGO guideline, which John will talk about. We do have endothelin A antagonists and SGLT2 inhibitors, and they constitute what's called foundation therapy. We have one complement inhibitor that is approved conditionally, and John will talk about APRIL and BAFF inhibitors. So what is very important is that IgAN is a very heterogeneous disease with very heterogeneous responses to treatment. And the idea is that we don't have firm evidence that combination therapy or what type of combinations works in a given patient. And a lot of times we need to resort to clinical judgment before personalized or precision medicine tools are going to be available. And I thank you for having me on this talk.
Well, thank you very much, Jay. I think we are moving on with the next presentation and then have some questions.
Right. So thanks very much, Jay. What I'm going to do now is take you through what is coming on the horizon, which is a tsunami of new therapies, which is fantastic news for our patients, but a bit of a headache for us nephrologists. Because if you remember, for the first 50 years, all we did in IgA nephropathy was give patients an ACE inhibitor and then scratch our head about whether we should give prednisolone. And that was about it. That was as exciting as it got. Now we have whole new classes of drugs coming for this disease, thank goodness. But how do we use them? And that's going to be a challenge we're all going to be facing over the next 5 to 10 years. So here are my disclosures. What I hope is that we move to a position from traditional medicine through to precision medicine. I've borrowed this from the oncologists. I think this has got to be our aspiration in nephrology. We had the 2021 KDIGO guideline, which really hadn't changed much from the first guideline 7 years previously. But what it did do is it highlighted the importance of offering patients the opportunity to be involved in a clinical trial. And what we are seeing now is we are reaping the rewards of the global nephrology community enrolling patients in clinical trials in IgA nephropathy. And so we have tried to move the field forward in this new update, albeit at a snail's pace compared to oncology, in terms of trying to deliver some degree of precision into our treatment choices for our patients. And as Jay showed in the algorithm, what we are trying to do is separate out those pathways involved in immune complex mediated glomerular injury from those pathways we see that occur in any patient who has lost substantial nephrons for whatever reason. So the glomerular hyperfiltration, the tubular interstitial response to proteinuria, systemic hypertension are as important in IgA nephropathy as in any other disease that causes significant nephron loss. But peculiar to IgA nephropathy is this IgA immune complex mediated glomerular disease. And until recently, we really didn't have very much to offer our patients, but that is changing. And ultimately, of course, I would like to think, and I doubt it'll happen in my career, that we get to a stage where we can diagnose patients with IgA nephropathy early when they haven't sustained significant nephron loss. We have safe, effective, and accessible treatments that can control this immune complex mediated glomerular disease such that patients don't develop significant nephron loss, and therefore there is absolutely no need for them to be on the therapies that Jay was talking about, RAS inhibitors, SGLT2 inhibitors, because we have identified the disease early, controlled the disease early, and nephrons are not being lost. That is an aspiration, and with the treatments we're starting to see, it could be a possibility over the next decade or so. But the sad fact of the matter is, rather like the patient Jay talked about, in my practice, when I see a patient for the first time, they already have significant impairment of kidney function, with an average GFR of around 50 mils per minute, which tells me they've lost at least half their nephrons before I get any opportunity to intervene in their care. And therefore, I have no choice but to be wanting to address both the IgA immune complex mediated disease, but also give them as many treatments as they need to control those downstream generic consequences of nephron loss. So if we are going to target immune complex mediated nephron loss, what are we actually trying to target? Where is the precision? Where are the ways we can actually assess this pathogenic cascade? So we know that IgA nephropathy is an immune complex mediated disease. We can measure these in the laboratory. We can't order a clinical test yet for them, but we measure them regularly in ours and many other laboratories. And we now have treatments that can specifically reduce these circulating immune complexes. We believe these immune complexes form because of an excess of a particular group of IgA molecules called galactose-deficient IgA. And these IgA molecules are sticky, they stick to themselves to form complexes, they stick to other serum proteins, and there are antibodies in the circulation that recognize them, all amplifying the formation of immune complexes. And we now have treatments that can specifically reduce the levels of this Gd-IgA1. There's a lot of data now suggesting that these Gd-IgA1 molecules come from the mucosal immune system, and that's the immune system that lines our respiratory, genitourinary, and gastrointestinal tracts. And we now have a therapy that can target mucosal IgA production within the gut. This, of course, occurs on a genetic background. It's highly polygenic, and we're using our understanding of the genetic background to identify new therapeutic targets. But actually, believe it or not, we are going to have the first trial of a gene therapy in IgA nephropathy starting later this year, and I'll talk a little bit about that later. And then, of course, we can target the kidney tissue itself in a number of different ways. And when we think about what happens when those immune complexes deposit within the glomeruli, we see a range of different responses, predominantly driven by mesangial cell activation. We can get inflammatory infiltrates, as was the case in Jay's case, with endocapillary hypercellularity and crescent formation. We can get fibrotic responses with podocyte injury and segmental glomerular sclerosis, and of course tubular interstitial fibrosis. The best way really to target all of these pathways is, of course, just to stop the immune complexes depositing in the first place. But actually, we may not be able to achieve that quickly, or we may not be able to achieve that completely. And so we have drugs now that can target the inflammatory aspects of glomerular injury. The big challenge we face in nephrology is really we've made little progress in targeting effectively those fibrotic pathways, with many failed trials, but there is a lot of work going on in this area at the moment. And of course, all of these pathways are amplified by activation of the complement system. And indeed, as Jay mentioned, there's a complement inhibitor already approved in the United States for IgA nephropathy, and we have a number of others in clinical trials. So when we come back to the guideline, we have included in the guideline the drug targeted release budesonide, which is specifically designed to target the mucosal immune system of the gut. I'm going to go through this very quickly because Jay covered this really nicely. We've had a phase 2 study and we've had a phase 3 study reporting on the efficacy and safety of this drug in IgA nephropathy, along with biomarker studies showing us where this drug is acting on that pathogenic cascade. You've seen these data already. While you take the drug, there's little, if any, loss in GFR, but when you stop taking the drug, the GFR declines and the proteinuria recurs. It's a relatively safe drug to take, but there is some systemic absorption of budesonide, and therefore you do need to discuss with your patients potential steroid-related side effects, although they're nothing compared to systemic steroids, and reverse on stopping the drug. These are data presented at the ERA, really showing that treatment of the gut mucosal immune system reduces Gd-IgA1, circulating immune complexes, and the IgG antibody that recognizes Gd-IgA1. So targeting in a very disease-specific way the underlying pathogenesis of this disease. But of course, we need to recognize this is a long-term disease. A 9-month treatment course is not going to cure this disease. Your patients really need to understand that. The drug works while you're taking it, but when you stop, the disease returns as it was before. And therefore, if we are going to use this drug, it's likely we're going to need repeated cycles, but we need to wait for more data to look at the safety and efficacy of that. So how can we target those immune complexes and that Gd-IgA1 in a slightly different way? Well, these are approaches that target B cells and plasma cells, which are the cells that generate immunoglobulins. And there are different approaches. The one most studies are using drugs that target B cell modulation, in particular two cytokines, BAFF and APRIL, which are critical for B and plasma cell survival proliferation, and in particular IgA class switch recombination. We have two monoclonal antibodies that target APRIL, sibeprenlimab, and zigakibart, or BION-1301. We have phase 2 data now published on both of these, which you can see on the screen. And at the ERA this year, we had a presentation of the interim analysis from the Visionary study looking at the 9-month proteinuria effect of sibeprenlimab treatment. And you can see the trial design here, a very typical placebo-controlled trial. And what we saw is 9 months of blocking APRIL with sibeprenlimab in high-risk IgA nephropathy patients led to a substantial reduction in proteinuria, a 51.2% placebo-adjusted treatment effect. And you can see this effect occurred early on the right-hand side in those UPCR data. And most satisfying of all, I think, is if you look at the safety data, really a very safe drug when you compare adverse events compared to placebo. This data is not published yet, but expect to see this publication at some point in November. We also had data on zigakibart presented at the ERA. Now, this is an early phase study, but we now have 100-week data blocking APRIL with zigakibart. Again, safety profile very similar to sibeprenlimab. And what we see here is sustained reductions in that pathogenic form of IgA, Gd-IgA1. We see improvements in hematuria. We see reductions in proteinuria. And perhaps most striking, in a high-risk IgA nephropathy population, we see no loss in GFR, close to 2 years out from exposure to this treatment. And what we need to remind ourselves is in placebo-controlled trials, over a 2-year period, we typically expect to see between 10 and 12 mils of GFR being lost in a high-risk patient. So early data, uncontrolled, but very exciting. And you're going to see a pattern here in terms of stability of GFR when we target specifically these B cells through BAFF and APRIL or even CD38 depletion. We do have 3 drugs that target not only APRIL but also BAFF, atacicept, telitacicept, and povetacicept. Telitacicept is only being developed in China, so I'm not going to talk any more about that. Atacicept is the most studied and has the most data, and povetacicept is currently in phase 3 in the Rainier trial. We have some early data published. You can see here phase 2 data for telitacicept and atacicept, and expect a publication on povetacicept around November time. But if we look here at these data, I want you to concentrate on the bottom left-hand corner. So what we saw here in the phase 2 is 96-week exposure to atacicept, substantial and sustained reductions in Gd-IgA1, resolution of hematuria in a large majority of the patients, substantial reductions in proteinuria, but again, stabilization of kidney function, or kidney function loss that is what we would expect to see in a healthy person, not a high-risk IgA nephropathy person. But as I showed you with Nefecon, when you stop atacicept, as you can see top right, everything comes back to where it was. You have not permanently cured this patient or modified the immune system. When you stop this drug, the proteinuria comes back. Well, we don't see this here, but we've seen it separately. The Gd-IgA1 certainly comes back, and the GFR starts falling again. So this is really important when we start thinking about all of these new treatments, is they don't seem to generate a permanent change in disease phenotype. And so when you're thinking about starting one of these treatments, at the moment, it's going to be a long-term treatment. And that's going to be important for patients to understand. So we've had the B-cell modulators. How about B-cell depletion? Well, our go-to drug would be CD20 depletion with rituximab, and it has no effect in IgA nephropathy. Can we deplete cells other than CD20 positive B cells to achieve our goal? Well, what we would most like to do is deplete plasma cells, the antibody producing cells, and the hematology doctors have lots of lovely toys to kill plasma cells, which is how they treat multiple myeloma. And one of these has made a transition to IgA nephropathy in recent times, and that is CD38 depletion. And so we've had 2 CD38 depleters in phase 2. One of these studies with felzartamab has been published, as you can see here. Mezagitamab was a little bit further behind, but both of these are in phase 3 now, and these are data for mezagitamab that were presented at the ERA, and there'll be longer-term data presented in November with a matching publication. And what you can see here is that with CD38 depletion, even though there's a relatively intensive treatment course over the first 22 weeks, out to 48 weeks, the impact on proteinuria has been sustained over 24 weeks off treatment. And at the bottom right-hand side, you can see GFR has been stable despite being off treatment for 24 weeks. So this is giving us another potential option in our patients that if we deplete plasma cells, we may well be able to get sustained remission off treatment. Now, what these data are showing is that the disease does seem to come back slowly with returning immunoglobulin levels, but at the moment, we are seeing sustained treatment-free remission, certainly with regard to proteinuria and stability of GFR. So exciting, but of course we need phase 3 data. And then we have the new kids on the block, the IgA degraders. And the rationale here is that we remove circulating IgA and immune complexes without targeting the cellular immune system. And so argenx have an approach that leverages the neonatal Fc receptor that is in early phase. And this is a very similar mechanism to efgartigimod, which is designed to remove IgG autoantibodies and approved for myasthenia gravis. No data yet, but this is something to look out for. We have the Biohaven approach, which is to remove IgA and IgA immune complexes through the acyl-glycoprotein receptor of the liver. And they have announced some early data, we've not seen anything at meetings yet, that they believe they can specifically reduce galactose-deficient IgA1 molecules with their particular drug. Again, we need to watch this space. There's a phase 2 IgA nephropathy trial ongoing. And then, of course, we have the potential for protease therapies. Bacteria generate proteases that digest antibodies. And there are a number of IgA proteases currently being looked at as potential treatment. And if you're in the field of transplantation, I'm sure you will already know about imlifidase, which is an IgG endoprotease, which is approved for highly sensitive patients, which will remove all circulating IgG within about 2 to 4 hours. Now, the challenge here is about repeated administration because of the development of anti-drug antibodies, but this is something that has been actively looked at, certainly for the IgA proteases. So how about genetic therapies? Well, we have, as I say, been able to leverage genome-wide association data to identify new therapeutic targets. And if you're interested in this, please take a look at this paper. But we also have a gene therapy coming from a company called PureSpring, which is looking to leverage the podocyte as a way of generating complement regulatory proteins to essentially make the glomerulus resistant to complement activation. We haven't had any patients into this trial yet, but this is something that will be coming, and I'm sure we'll hear more about it over the coming months. But of course, targeting the kidney has really focused on complement activation and inhibition of complement. We have monoclonal antibodies, peptides, small molecules, RNA interfering therapies, and as I mentioned, gene therapies now. The most advanced of these are targeting factor B of the alternative pathway and the small molecule inhibitor iptacopan, which has now got phase 2 data and phase 3 data and is approved on the accelerated pathway in the United States for the treatment of IgA nephropathy. What happens when you stop iptacopan? Well, this is data from the ERA earlier this year. And just like the BAFF and APRIL inhibitors, just like Nefecon, when you stop the complement inhibitor, surprise, surprise, everything goes back to where it was before. The complement biomarkers return to baseline, proteinuria returns to baseline. But as you can see on the right-hand side, when you restart iptacopan, proteinuria falls again. So again, this is a treatment that works while you're taking it, but actually when you stop, as you might expect, everything returns to baseline. And therefore, again, this is a therapy we're going to need to think of as a chronic therapy. We have monoclonal antibodies targeting C5. Ravulizumab, I'm sure you know well from atypical hemolytic uremic syndrome and C3G. We have a phase 2 study that's now been published, and the phase 3 ICAN study is recruiting at the moment, when we'd expect to see proteinuria data from this study in some time in 2026. We also have RNA interfering therapies that are designed to stop the translation of mRNA to protein, and we have these drugs being evaluated to target factor B, C3, and C5. The first one of these was cemdisiran. The trial finished. The drug was safe. It delivered what it was supposed to, reducing C5 and reducing proteinuria, but it's not been taken forward. We have another drug that targets C3. And this data was presented at the ERA, and I'll just quickly talk about it. So what you can see for an RNA interfering therapy is this is a silencing RNA, so a double helix oligonucleotide, and it has sugar molecules attached to it that mean it targets the liver through the acyl-glycoprotein receptor. So it selectively accumulates within the hepatocytes, where it stops the translation of C3 mRNA into protein. As you can see here, in vaccinated patients, it's well tolerated and safe, and it does exactly what you hope. It drops circulating levels of C3, and it impairs all of those complement assays that we traditionally use to evaluate the complement pathway. Importantly, what they saw in this open label study was there was a resolution of hematuria in a large number of patients. GFR remained stable, although this was a short-term 24-week study, and proteinuria fell in most patients. So we have an opportunity here for C3 inhibition with a silencing RNA as a potential therapy. But most advanced in terms of RNA interfering therapeutics are drugs targeting factor B, and in particular cefaxacen, which is being evaluated in the Imagination clinical trial. There's another small open label study looking at ARROW CFB, but we have no data on that at the moment. And this is data for cefaxacen from the very early studies. And if you just look at the bottom panel, what you can see is if you target factor B production in the liver with an antisense oligonucleotide this time, you get reductions in factor B, the breakdown products of factor B, BA and BB, and you get suppression of alternative pathway activation and a reduction in proteinuria. So it's going to be fascinating to see the impact in the large Imagination phase 3 study of this antisense oligonucleotide. So we are moving forwards. You can see that we are going to need a precision medicine approach because we're going to have so many treatments to choose from. And the hope is that with these new treatments, we will have new ways of assessing disease activity and choosing the right therapy for the right patient at the right time. We've started doing it here, splitting up the disease specific from the generic treatments, but we've got a lot more work to do to add in all of these new therapies and see how they stack up against one another. We are seeing combination trials even within the CKD type treatments, and here you can see adding sparsentan, dual endothelin angiotensin receptor antagonism on top of SGLT2 inhibitors. We get added value. So not only is there a lot of excitement about those disease-modifying therapies, but we're now seeing how we can use those CKD-type treatments more effectively in combination. But as I say, this is going to be a real challenge. And the commonest question I get asked is, how on earth are we going to choose the right drug, and which drugs can we safely combine together? We need biomarkers desperately, and I would imagine that over the next decade, we are going to see a massive growth in novel biomarkers that will help us make clinical decisions, but we're not there yet. And so all I can tell you is that we've had 3 iterations of the IgA guideline. And I would imagine we're going to see changes ahead, at least every year or every 2 years. So expect lots of new data and expect lots of discussions on how on earth we put all these together for our patients. So thank you very much for listening.
Well, thank you, John. This was exciting. And I think, the KDIGO guidelines needs to be updated probably every 3 months or so. What's happening now? It's a real tour de force through IgA nephropathy. But I want to come back to Jay and his presentation. He mentioned Stop IgAN and the testing trial. What role in your practice does still or not still anymore oral glucocorticoids play?
So that's a great question. So I'll answer. There are two answers to your question. The first is obviously if you're in a resource poor situation, that's probably the only drug you have available, and there's certainly nothing wrong with it. You just have to choose the right patient for the right drug, right? So the way I look at IgA nephropathy, and this may be somewhat flawed, is that there are flavors of inflammation and there are flavors of fibrosis and everything in between, right? So if the patient comes in with a rapidly declining GFR and there's a lot of fibrosis, very little fibrosis, I might say for a month or two, at least get the process started with the corticosteroid. And then transition over either simultaneously or sequentially to one of these more specific targeted therapies, which affect the specific drivers of IgA nephropathy, like complement inhibitors and maybe TR budesonide. But if the patient has sort of mixed inflammatory or predominantly fibrotic, I might say, look, this is not the right patient for, corticosteroids, at least at that point, right? So for me, the biopsy is very, very important. I don't look at vintage biopsies of 4 or 5 years, which unfortunately has been when you look at patients enrolled in clinical trials, there's no requirement that the biopsy has to be right in close proximity to enrollment. So I do biopsy my patients several times during the course of their, career, if you will. And that does provide a lot of information aside from proteinuria, hematuria, and GFR.
And one more from my side. So the case is very, very nice, and it shows roughly a 90% reduction in proteinuria. But how did you convince actually the healthcare or those people paying for the patient's healthcare to use sparsentan and the reduced dose of DRB in this patient?
Yeah, so it's tough, and there's no straight answer to your question, but we have to be innovative and see what we think helps the patients the most, because it's very clear when you stop the TR budesonide, things will just revert back to normal. So we have to use a little, creative thinking, if you will, to get these medications approved, because I think they're important. And as John said, you don't have a month or a year or 2 years where therapy is going to work and then you can take the patients off. This is a lifelong disease, and you have to figure out how best to control the disease long term.
John, over to you. I mean, this is an exciting field, and I understand, that there are like 500 new drugs coming out probably the next couple of decades. And of course, as a general nephrologist, we are asking ourselves, where are we heading towards? And what is your approach? Do you start like these novel treatments if you get approval to use them in parallel, or are you still waiting basically ACE inhibitor, SGLT2 inhibitor, and then moving on to DRB or let's say sparsentan?
Yeah, I think this is always comes up, and I think we need to separate out the two discussions. Forget who's going to pay for the drug. What should the patient get? This patient, Jay's patient, has an active glomerular disease, and he's young, and he's already got evidence of significant nephron loss. So what do we want to achieve? We want to control the glomerular disease. And so what do we have available? Well, for me, it would be Nefecon in the UK. That's what I would want to give him. And I accept that he has got significant nephron loss. So what are the best drugs to give him for that side of things? Well, the best drugs are sparsentan and an SGLT2 inhibitor. Those are the best things. Now, whether I can practically give them to him because of the healthcare system I work in is a secondary issue. And I know it seems a bit kind of philosophical, but I think we always need to start with, what do I want to achieve for the patient? This is a young patient. If I don't get things under control quickly, he is almost guaranteed to end up on dialysis in his lifetime. And therefore, that would be my goal. So I will do what Jay does, which is I'll have to be careful who watches this, but I will manipulate the healthcare system I work in to make sure my patient gets the treatment I want him to get. And of course, I can start him on, you're the same as me. You know, we have those proteinuria levels in Europe. The FDA were wonderful in that the full approvals say you can use these drugs in anyone you believe is at risk of progressive loss of kidney function. We, on the other hand, have to say that we can only use them in patients who have more than 1 gram per gram of proteinuria. It doesn't mean to say, so what I would do is start sparsentan and Nefecon simultaneously, because he has that. It doesn't say I can't start both together, because to the letter of the law, he does have that high level. So my view would be, I would do exactly what Jay did. I would be controlling the immunology of the disease. And at the moment, the drug I have is Nefecon. Next year, I might have a BAFF in April, and then I might be weighing up one against the other. But at the moment, I don't have that. And I would be wanting to optimize the care of his remaining nephrons with dual endothelial angiotensin receptor antagonism and an SGLT2 inhibitor. Because I don't think that is the best way I'm going to stop him developing kidney failure in his lifetime at the moment.
Based on what has been now proposed, our target proteinuria is as low as possible, I would say. Do you think that trial design will change and the inclusion criteria for the trials will also lower the threshold of proteinuria to, for instance, 0.5, also based on your radar data, or is that difficult?
Yeah, no, I mean, we understand that people in clinical trials are not the full range of people at risk. The challenge, of course, is we want a result within 2 years. And if we recruit patients who have lower risk disease, still very high lifetime risk, but lower risk, little is going to happen in a 2-year time period. And therefore, it becomes harder to show the effect of a drug. Therefore, you need far more patients, or you follow the patients for longer. And the sad fact of the matter is that will cost a lot more money, and pharma companies don't want that. So we accept that the current criteria do not encompass everyone at risk. Now, the beauty is, of course, if you live in the United States, the FDA have understood that, and they've let Jay decide who he thinks is at risk of progressive loss of kidney function. And it will come as no surprise the KDIGO guideline specifically says, we believe that anyone with more than 0.5 grams is at risk of progressive loss of kidney function, as a way of referring back to. And my guess is the wonderful data from Scandinavia showing even lower levels of proteinuria, as we do, are associated with an increased risk, means that over time the KDIGO guideline may drop that proteinuria threshold even more, but we just aren't at that stage yet.
And I think, the beauty of the Scandinavian data is also to show that if the GFR at baseline, so to say, is around 30, you still see this massive effect of proteinuria on lifetime progression to end-stage kidney failure. And I think this is really nicely shown over and over again, and your data have been replicated in a lot of different populations. So that's really, like, also from this side, a great advantage we are seeing. So last one from my side is probably asking you as a GN physician. I usually try to find a way to stop inflammation permanently. So to say, in ANCA vasculitis, we roughly know how to do it, but isn't that frustrating if you give a drug, you stop it, and then basically the disease comes back? And do you think that agents like felzartamab, once the phase 3 trial is there, will show that you can effectively stop the drug and then disease is not coming back again? Or do you think that none of
I think it comes down to fundamentally what you think is going on in this disease. If you truly believe it's an autoimmune disease and there's oligoclonal expansion of cells generating autoantibodies, then potentially you could get rid of those with deep B-cell depletion, just like is being tried in lupus and ANCA vasculitis, getting to the point of CAR T-cell therapy. My personal view is this is a process driven by every mucosal IgA response in the body. And therefore, we need our mucosal immune system. There isn't an oligoclonal group of mucosal B cells that are the problem. So we can't deplete our whole mucosal immune system. This is always going to be there. And therefore, it's unlikely we're ever going to be able to cure this. We'll be able to put our foot on the brake and slow it down. And some people have very slow disease anyway. So we might just need a very gentle tap on the brake. Other people have really very, very rapidly progressive disease, in which case they need their emergency stop, full foot on the brake with very heavy duty treatment. And as Jay mentioned, this is such a heterogeneous disease. We're going to need to not have one size fits all. We're going to tailor the treatment to the patient. And of course, if I was treating a 20-year-old, I'll feel very comfortable in a fit 20-year-old giving them a depleting strategy. If that 20-year-old becomes 50 and they're overweight with diabetes and have had a cardiac event and perhaps a foot ulcer, I'm not going to want to necessarily deplete their plasma cells for 6-8 months, because that may not be as safe. So I think we're going to need lots of different approaches. And Jay, I mean, I talked, that was a very typical case, but you presumably see as heterogeneous a population of IgA as I do. Some need a gentle press on the brake to control things. Others need a lot more treatment.
Absolutely. And I think, this move towards precision medicine will hopefully, as you said, find biomarkers that will help us. Otherwise, we are resorting to the usual, biopsy for me is a gold standard. And along with, proteinuria and hematuria, got to put the whole package together I have milestones 3 to 5 years to see what's going on.
Yeah, and the beauty is managed to convince all the sponsors to do repeat kidney biopsy studies. So hopefully that will give us a bit of help.
Should we be afraid that with this current study designs, which give us studies that run for, say, 2 years or so, which give us some information on EGFR drops, but which test drugs that we apparently have to use for years, and not just for 2 years, but maybe for decades, that we might oversee some side effects with these medications, which are, for the vast majority of us, quite unfamiliar up to now?
Yeah, I mean, I completely agree. I think if we look at complement inhibition, we can be relatively confident from the data from eculizumab and ravulizumab in C3G and aHUS. We've had people on those drugs now for quite some time. Still a short time in the grand scheme of a 30-year-old who's got another 50 years to live, but we have got information on complement inhibition outside of IgA nephropathy. We've got data on complement inhibition in the combination with other immunosuppressants in terms of recurrent disease. We have data from Ben Lister now in lupus, so BAFF inhibition, not BAFF and APRIL, and not APRIL, but we do have data on BAFF inhibition. And of course, we can go to the hematologists to look at depletion, CD38 depletion, and we ourselves have, and the rheumatologists have lots of experience of CD20 depletion. So I agree we don't have data in IgA nephropathy. I agree there is going to be a risk of long-term use. And as long as we're aware of that and we can discuss that with our patients, and there's a continual collection of data, then I think we always forget, what's the risk of doing nothing? Dialysis. What's the 5-year mortality for dialysis? 5-year mortality being on dialysis is worse than 7 of the top 10 most common cancers. And we always think, oh my goodness, what if we're doing something? But what's the alternative? I guarantee you that patient of Jay's will be on dialysis. If he'd been put on a RAS inhibitor and SGLT2 and none of the nutrients, he would have been on dialysis, I think, Jay, in the next decade, if not sooner?
Absolutely. 10 years within guaranteed, unfortunately. And also, I think it also plays into this and trial enrollment. Young people are very enthusiastic about enrolling in clinical trials. So all these IgA nephropathy trials have had no problems enrolling. The problem is going to be now with all these drugs. How can we get fresh patients?
And everyone's going to want to stop them. And I guarantee you, we will have patients on this and we'll say, let's stop and see what happens now.
Right, exactly.
Say, there'll be some people with very mild disease who won't need retreatment perhaps for 5 years, 6 years, and others where the proteinuria will just bounce back very, very quickly. So we are going to learn as we go along. I always use the example of UVAS. UVAS is a wonderful organization but it's been doing lots and lots of trials, but we're almost about working out how to induce remission in ANCA vasculitis. We're probably not so sure about how to maintain remission for the rest of someone's life. And UVAS have been working on this for 30 years and had a lot more treatments than we have. We are at the beginning of a UVAS type approach of running trials about how do we get people into remission safely and quickly, and how do we maintain remission safely and quickly. And, you know, I mean, Andreas is clearly very involved in the ANCA vasculitis, but that's where I draw comparisons, is we are at the beginning of that journey.
And again, just to repeat what Jay said before, when we go for years of treatment, we should do biopsy from time to time, as long as we do not have better biomarkers from the serum or from the urine, just to know what's going on in the kidney and how far there's still some kind of activity. So that's what you would still recommend to us.
That's what I would do, especially when we are changing, thinking of changing treatment. I think it's a perfect time to rebiopsy, reevaluate how much fibrosis, how much real IgA specific activity there is. So it does play a big role in my practice, at least, too.
And in mine. I mean, I didn't used to rebiopsy my IgA-nephropathy patients because I had nothing to give them. So I could observe something very terrible, but I still didn't have anything. Now I do have I can get an actionable result from a biopsy, and I can change therapy. And I think we're going to see IgA managed in very similar ways to lupus and ANCA, now that we know we've got an alternative treatment to give.
My last question would be to standard treatment as of 2025. In the new KDIGO recommendations, you still advocate to go for very low blood pressure targets, 120, and very low sodium targets, actually 2 grams, which is, at least in Frankfurt, and I guess it's similar in New York and in the UK, maybe better in Innsbruck, where people live healthier, but quite difficult and really affecting the standard of life for these patients. So with all this new medication, do we still need this very strict targets? And the second question, and my last question actually, you are kind of reluctant with regard to SGLT2 inhibitors. And you just stated it before, you said plus minus SGLT2 inhibitors. We just saw an NET paper by some leaders in the field who said, well, maybe they won't work properly in people who are not obese with glomerular disease. So do you also see the SGLT2 inhibitors just as an option for these people rather than standard treatment?
So I'm going to just say, one word about SGLT2s. They not only affect the kidney, but there's a cardiac protection as well. And this is a lifelong disease. So if you look at CKDs, and I think the data are very, very strong across the board that these are cardiorenal drugs, not just renal drugs, right? So I'm very, very forthright to my patients. Yes, your pill burden is going to increase, but we're looking at a lifelong disease. And I think SGLT2 should be there if it's within the affordability area of patient care. Now, a lot of countries don't have SGLT2s because of expense. But if you're able to put these patients on and there are no side effects, I think they should be on SGLT2 inhibitors. The plus minuses, I think, is more about availability and cost.
Yeah, I mean, what I'm cautious against is using them as a replacement for a treatment that actually treats the underlying disease. And the big worry is people have thought, and you don't even need to make a diagnosis. You've got impaired kidney function proteinuria, RAS inhibition, SGLT2, MRA, be a cardiologist, put them on those, and then you can stop thinking and don't worry anymore. That is a really negative way forwards. I really worry about that, but I hear it all the time. We need to, precision diagnosis medicine starts with making an actual diagnosis. So make a diagnosis. We've split the two up. We're not saying you shouldn't use an SGLT2, but actually you can add it. And certainly in our practice, most people are coming with significant nephron loss, so need it. But I wouldn't be putting a 30-year-old who I've caught with a GFR of 90 on an SGLT2 inhibitor for the rest of their life if I can control the underlying disease. Remember, all of these trials were done in people who had active, uncontrolled kidney disease. We don't know whether we need them. If we actually have a disease, we stop dead in its tracks. And some of the data I showed you suggested we can achieve that. And then if you have a disease that's completely under control with no loss of GFR, we need to then question what is the value addedness of additional treatments. Because if my patients are going to take one treatment, I want them to take the treatment that's going to control their kidney disease.
And one word maybe on sodium and blood pressure.
Again, coming back to the fact these people can potentially develop cardiovascular disease. So just like you, patients may attain that sodium restriction for the 24 hours prior to coming to clinic when you check their urinary sodium. That's not going to be the case. So we have to try and work towards a healthy, balanced diet with reduced sodium intake, and we need to try and get that blood pressure as well controlled as possible within the realms of what is possible for a patient. So I don't have a problem with that, but I don't have the expectation, certainly for dietary sodium restriction, unless you live in Aachen and your nephrologist is Jürgen Flöger, that you're going to be able to achieve this consistently.
But then you also have a control group which has only a GFR loss of, I don't know, -1.5, which is unseen in other populations.
That is true, and I know Jürgen will be certainly having a word in my ear if he watches this. So it can work, but if it's sustainable for 50 years of a 30-year-old patient's life, and we have to go where we think we're going to get most value, and I would certainly not sodium restrict instead of a disease modifier. If we can get that sodium down, fantastic.
Okay, guys, I think we're at the end of the hour. It was exciting and very, very nice. And I just need to comment on IgA and ANCA, although I like ANCA more, but I'm very jealous what I see in IgA nephropathy, because this progress is unheard of. And I think we are far away in the ANCA field, unfortunately, to see these developments. So a great 1 hour for us, very educative. And thank you for being our guest today.
Thank you.
Bye-bye.
Bye.
Goodbye.